Yeah, hello everyone. My name is Anori Victor. I am a neurology aspirant and I will be doing the Ching Cheng's comprehensive review in clinical neurology. So we've done questions 1 to 22 and right now we are about to do question 23. Actually, we'll be doing 23, 24, and 25. So let's begin. For 23, which of the following cranial nerves would most likely be affected in a patient presenting to your office with papilledema, headache, and significant obstructive hydrocephalus? A. The facial nerve. B. The trochlear nerve. C. Abducens nerve. D. Trigeminal nerve. And E. The oculomotor nerve. Okay, so we have a patient who comes in here, and the patient actually has signs of increased ICP, increased intracranial pressure, with the classical symptoms including papilledema, headache, and significant obstructive hydrocephalus. Now, there is a particular nerve, and whenever you have an increased ICP, that nerve is very susceptible to causing a palsy. And that nerve is the abducent nerve, cranial nerve number 6, which is option C. So let's have a brief talk about it. Okay, so let's talk about the sixth cranial nerve, which is the abducens nerve. So basically, this nerve, its origin begins in the brainstem at a place called the facial colliculus. Now, the facial colliculus is actually a very prominent landmark in the floor of the fourth ventricle, and it's actually formed by the fibers of the facial nerve that loops around the abducens nucleus in the pons. Now, this nerve then travels anteriorly through the brainstem to exit the ventral surface of the pons. It exits the brainstem at the inferior aspect of the pons and travels through the subarachnoid space towards a part called the clivus. Now, from here, it enters into the Dorello canal, which is a channel that is at the lateral aspect of the posterior clivus, just right by the petrous bone. Now, this canal travels superiorly, taking the nerve upwards towards the orbit. At the exit of this Dorello canal, there is something we call the petroclinoid ligament. Now, from the word petroclinoid, basically, this ligament runs between the petroid ridge and the clinoid. Now, our sixth cranial nerve basically runs under this ligament, and this ligament holds this nerve against the medial petrous ridge, just like a seat belt. Now, it then enters into the cavernous sinus, where we have cranial nerve number 3, number 4, and V1 and V2, which are cranial nerve number 5, the ophthalmic and the maxillary divisions. Also, we have the internal carotid artery and the sympathetic that also runs with it. Now, it's important to note that the sixth cranial nerve is the most medial of other nerves. In fact, it is the only nerve that runs into the cavernous sinus itself rather than its walls. It then exits the cavernous sinus, enters into the orbit through the superior orbital fissure, and here it is joined by cranial nerve number 3, which is our oculomotor nerve, and number 5. Now, cranial nerve number 2 is actually in close proximity with this nerve. Now, as soon as it enters into the orbit, it makes an immediate turn laterally and innervates the lateral rectus muscle. Now, there are actually six syndromes of the sixth cranial nerve that we must know. The first is called the brainstem syndrome. The second is called the elevated ICP syndrome. The third is called the petrous apex syndrome. The fourth is called the cavernous sinus syndrome. The fifth is called the orbital syndrome. And the sixth is called the isolated sixth nerve palsy. Now, we're going to be talking about each of these. Now, talking about the brainstem syndrome, now there are very, very important structures that runs in close proximity with the sixth nerve nucleus, and usually we have the pyramidal tract, we have the pyramidal pointer formation, we also have the facial nerve. So, if you have a lesion, be it a compressive lesion, an ischemic, or an inflammatory lesion that affect the cranial nerve number 6 in here, it's unlikely to have an isolated cranial nerve number 6 palsy. Usually, you have other cranial nerves or pyramidal tract involvement. Now, there are specific syndromes, but the key point to remember is that you will have other deficits if you have a brainstem syndrome, especially motor deficits. So we could have things like the famous Millard-Guber syndrome, which is a sixth cranial nerve palsy, a seventh cranial nerve palsy on the lateral side, and a contralateral hemiparesis. Or you just have the Raymond syndrome, which is the sixth cranial nerve palsy and the contralateral hemiparesis. Now, that's for the brainstem syndrome. The next kind of syndrome is called the elevated ICP, the elevated intracranial pressure syndrome. Now, as this cranial nerve passes through the Dorelus canal, it is susceptible to changes in the ICP, and that is because it is tethered in the Dorelus canal. So, if the brainstem moves with pressure, be it an increase or a decrease in intracranial pressure, this will cause a stretch of this nerve, and this can lead to bilateral isolated pulses. Now, as nerve exits the Doralus canal and travels under the petroclinoid ligament, it is vulnerable to infections from complicated otitis media. And this region rarely gives isolated palsy because other nerves are present here. In fact, sometimes you may also see hearing loss, and if you see hearing loss in the presence of a sixth nerve palsy, you should think of the Petrus apex syndrome. Now, after it exits the cavernous sinus, things get a little bit complicated, and that's because of all the nerves that are in close proximity. So, we rarely have isolated palsy when you have cavernous sinus syndrome. In fact, we define cavernous sinus syndrome as deficit of two or more of the structures that enters into the cavernous sinus. And these structures include things like the cranial nerve number 3, 4, 5, and in particular V1 and V2, the internal carotid artery, the carotid sympathetic plexus, and the pituitary gland, the optic nerve, the optic hairs may also be affected in this syndrome. Now, as the nerve enters into the orbit, it takes a sharp lateral turn after the superior orbital fissure to innervate the superior rectus muscle. And due to the fact that we have other nerves in this place, you may have something we call superior orbital fissure syndrome or orbital apex syndrome, and not an isolated palsy. So you have things like cranial nerve number 2, 3, and 5, including 6 that may be affected. And the last syndrome is what we call the isolated sixth nerve palsy. We call that the transverse myelitis of the cranial nerve number 6, and it's most likely microvascular or post-inflammatory. Now, but it's actually a diagnosis of exclusion, and you must rule out other 5 syndromes before you can make this diagnosis. So, question 24. We have a 34-year-old woman with diabetes who presents to your office complaining of mild left eye ache and an increased left pupil size that she noticed in the mirror yesterday. On examination, you'll find that her right pupil reacts normally to light, but her left pupil is not reactive to direct and consensual light or to accommodation. What do you suspect as a likely diagnosis or the likely cause? A. Agric Robinson's pupil from neurosyphilis. B. Optic neuritis. C. Aneurysmal compression of the oculomotor nerve. D. Tonic or Aedis pupil. And E. Diabetic cranial neuropathy. Now, looking at these options, looking at the question, what do we think? So, the important keynote to take here is that this patient has dilated left pupil, so there is mydriasis, and the right pupil is fine. Now, that pupil that is dilated is not reactive to both direct and consensual light. At the same time, that pupil is not reactive to accommodation. So that tells me that there is probably something going on with the parasympathetic innervation of the eye, because remember that your parasympathetic innervation from the oculomotor nerve will actually help with your pupillary constriction. At the same time, it also helps with accommodation due to innervation through to the ciliary ganglion. At the same time, it also helps with consensual light reflex and direct light reflex. So let's try to eliminate. We have A. Agric-Robinson's pupil from neurosyphilis. Now, we all know that Agric-Robinson's pupil is also known as the prosthetist pupil. And basically, what happens is that you have an individual whose pupils are small, so they are myotic and they are uneven in size. Now, these pupils do not react to light, yeah, but they constrict to accommodation. So that's not the case in here. So options A is out. Options B is optic neuritis. Now, in optic neuritis is something we call RAPD, relative afferent pupillary defect, right? And that is not seen in this option, in this question rather. We have option C, aneurysmal compression of the oculomotor nerve. Now, if you have an aneurysmal compression of the oculomotor nerve, what happens is that we have affectation of the parasympathetic fibers. And basically, these patients will have dilated pupils, yeah, but that will not cause the non-reactivity to direct and consensual light, neither will it affect accommodation. D, tonic or Aedis PPO, we'll go back to that. And E is diabetic cranial neuropathy. Now, if you have a diabetic cranial neuropathy affecting the oculomotor nerve, what happens is that you're going to have issues with the extraocular muscles, but that will typically not affect the dilation of the that will not cause the pupils to be blown out. So it usually spares the parasympathetic innervation that is at the periphery of the oculomotor nerve. So let's talk about options D, tonic or AD's PPO. So tonic PPO, also known as the AD's PPO, is actually thought to be as a result of a lesion to the postganglionic parasympathetic pathway. So either the ciliary ganglion or the short ciliary nerves. And most often than not, we attribute this to a viral etiology. But you should know that there is really lack of evidence. So usually what happens is that since you have little to no parasympathetic innervation, we have something we call mydriasis in the affected eye. So the eyes are dilated, and they are so dilated, they do not constrict to light, neither do they constrict to accommodation. And why is because the sphincter of the iris, that the iris sphincters and the ciliary muscles are basically paralyzed. Now, sometimes not all of the nerves are affected, and if you just have a segment affected, you can have something we call sectorial paralysis of part of the iris sphincter, and this may actually be one of the earliest signs of this entity. Now, because the eyes are dilated, your patients may have photophobia, eye pain, and even blurring of their vision. And because there's denervation, usually what happens is that they are usually very sensitive, so they are super sensitive to cholinergic agonist. Um, So usually to test this, you actually use pilocarpine at very low concentration of about 0.125%. Now, in the normal eye, if you put this 0.125% of pilocarpine, you will have no reaction. But in the affected eye, since it's so denervated and it's now very sensitive, if you put 0.125% of this pilocarpine, you have constriction of the affected eye. Now, with time, what happens is that you now have return of accommodation. So you have slow, sustained constriction to accommodation. Yeah, and when you put and also you have slow redilation after near constriction occurs. Now, at baseline, the pupils would be slightly decrease in size. So the pupils actually decrease in size over time in ambient light, and although the response to light would remain the same. So basically, the pupillary light reflex does not improve, but you actually have an improvement of the accommodation reflex, although it remains slower than normal. Now, we call this the light near dissociation, and sometimes this disease entity is also associated with a decreased or diminished deep tendon reflex. And when that happens, we call that the Holmes Edis syndrome. So we've established that for question 24, the answer is options D. So 25, in the chronic stage of the disease process, which of the following pupillary findings are most often seen? So if you remember, we said that the pupils are smaller than their baseline, and at the same time, you may have you may have return of accommodation, but the pupillary light response is usually gone. So the first is meiotic. So yes, it's meiotic. An interpupillary response, that's false. The D is meiotic, yes, with minimal to absent light response, okay, and minimal to absent accumulation, that is wrong. C is myodratic with minimal to absent pupillary light response, so myodratic is wrong. D, myodratic is wrong. And E, meiotic, yes, with minimal to absent pupillary light response, yes, but intact accommodation. So we can say E is the answer.